Yeah. The second talk is based on a question that came on the Glaucoma Net in the United States about, 17 years ago, when a famous glaucoma specialist from Canada said that, everybody with pseudoexfoliation should have a CTR placed in their eye and all that kind of stuff. And one of the famous glaucoma specialists in Baltimore said that everybody with pseudoexfoliation has hyperhomocystinemia and should be treated. And I said, there's no data. I started looking at this. So with the grace of all the wonderful people at Arvind, we were able to do a spectacular study with almost no cost. The intraocular lenses were donated by Alcon. They had nothing to do with the study, didn't analyze the study. I don't even know if they know it's done. And the CTRs were supplied free to the patients by Oralab, which is Arvind. We all know, this is from our prevalence study that we did 20 years ago, that pseudoexfoliation is very prevalent in India. And we also know that both pseudoexfoliation and cataracts increase with age. So we decided to do a study to see what the best way to treat these people who have cataracts or have pseudoexfoliation. So this was a 6-arm prospective study with almost 1,500 patients that we were able to complete amazingly in a little bit over a year. All had to be over the age of 40 years and requiring cataract surgery. They all had visually significant cataracts. And our control group were people who had cataracts but did not have any other comorbid eye diseases. So visually significant cataracts, willing to do phaco, and endothelial count was important of over 1,500. And we excluded, and this is important also, patients who had pre-existing phacodenesis or pupils smaller than 3 millimeters. We followed everybody up for a day, a month, 3 months, a year, and yearly for 10 years. And during COVID, we missed year 9. That was one of the things that happened. So these are the 4 groups. In the pseudoexfoliation group, either a 1-piece or 3-piece IOL, with or without caps or tension rings. And we have about 235 patients in each group. In the control group, who just had cataract, it was either a 1-piece or 3-piece IOL, about 240 patients in each group. No CTRs were done. We looked at systemic issues. We had a history. We did blood drawn for glucose, cholesterol, homocysteine. We measured blood pressure, did a 12-lead EKG, and we did blood sugar counts. We also did a total ophthalmic workup for visual fields, gonioscopy, specular microscopy, the whole deal. And we defined things before the study began of an IOL decentration of greater than 1 millimeter, and a capsulotomy. You have to have at least 1 line of vision lost. And we defined glaucoma based on visual field and based on disc, but not based on intraocular pressure at all. So as you would expect, there were differences in the group. Interesting, the pseudoexfoliation group was a little older and had more males, as you would expect. Regarding systemic associations, it goes all over the board. There's all kinds of reports of the Blue Mountain study of people dying prematurely. There's evidence that homocysteine is a big problem. So we wanted to find out what the story is. So significant things was systemic blood pressure was higher in people with pseudoexfoliation. There's no significant difference in homocysteine levels, absolutely none whatsoever. We found that LVH was very significant, and all cardiac morbidity was important. We'll talk about that later on, but those were the important things we found different in all the testing we did for pseudoexfoliation. So there was a strong association with systolic hypertension and mean arterial pressure and LVH, no association with diabetes, cholesterol, or hyperhomocysteine. What about intra and postoperative complications? Well, preoperatively, the intraocular pressure, as you might imagine, even though there were only a few people with glaucoma in the pseudoexfoliation group, was slightly higher. After that, for the first year, there was no significant difference. If you look at the intraoperative complications, that is during surgery, there was no significant difference. Now, granted, these are all surgeons who are really impressive and can do up to 100 cataracts in a morning and are very experienced and have great hands. And my wife was operated on by one of them. But this is not the average run-of-the-mill cataract surgeon, but that's important to realize. On day 1, we saw more corneal edema in the pseudoexfoliation group. But after that, there was no different on day 30 or day 1, and there was no other significant difference in iritis or IOL centration, phimosis, no difference. What about glaucoma? This is at 5 years. So I'll talk about 10 years. We haven't analyzed that yet. There was a 7-fold almost, or 5-fold increase in the numbers of the people who develop glaucoma by field and disc at 5 years. So that's important for you to realize. That's lesson number 6, to make sure you look at people with pseudoexfoliation and assess them for glaucoma more often than you might have, depending on their age. What about at 10 years? This is brand new stuff, just off the press, so to speak. Not published, but off the press. We did pretty well in recruiting, except for death. We were able to follow 82% of patients for 10 years, which is pretty impressive. We had a high rate of mortality. Now, whether or not this is more than age-adjusted norms, I don't know. And whether or not this was more in the pseudoexfoliation group than the non-pseudoexfoliation group, I don't know yet either. But these are the rough numbers. Means are deceiving. What about IOL decentration? Do you need a CTR? No, you don't need a CTR. There's no difference. What about capsulotomy? Do you need to do, or there's an increased risk of capsulotomy in people with pseudoexfoliation? Nope, no difference whatsoever. And no difference in 1-piece and 3-piece IOL, and no difference between CTR and no CTR. There it is. What are the risk factors for IOL decentration? Although it didn't happen very often, what are the risk factors? Well, one of them is denser cataract. The second one was capsular phimosis, probably weaker zonules. And one was a rhexis that overlapped the IOL. So these are things that are happening that you should be aware of. What about that risk with Cox proportional hazard analysis of need for capsulotomy? And again, it's a 3-piece IOL and older people and people with a bad rhexis. So those are things important. What about vision? It's interesting that the vision in the pseudoexfoliation group at almost all time periods was significantly worse than the non-pseudoexfoliation group. We're looking at the data now to figure out if it's macular degeneration, if it's because they develop glaucoma, whatever the reason is, corneal decompensation. I can't answer that at this point, and I hope I can at some point. It's similar to the rates in other studies showing that there is a significant risk of cataract surgery in those groups too. Okay, conclusion. This is the first large-scale prospective comparative study with long-term follow-up results looking at pseudoexfoliation eyes undergoing phacoemulsification. These were all phaco, no small incision cataract surgery. In eyes who have at least a 3 millimeter pupil without phacodenesis and do not have a higher risk of IOL decentration or PCO, a CTR is not required in these eyes with or without intraoperative phacodenesis. And IOL choice, 1 or 3 points, it doesn't really matter. You can have a one piece or 3-piece, it doesn't really matter. Thank you very much. I appreciate the opportunity to be here.
Thank you so much for such lovely talk.